So without further ado, it is my great pleasure to present our first speaker of the day, Ros Moore. Ros Moore is the Chief Nursing Officer for Scotland since 2010. In this role, she advises the Cabinet Secretary and Ministers on all matters relating to nursing, midwifery, and the allied health professions, and is the Director with lead responsibility for person-centered care, healthcare-associated infection, and regulation of healthcare professionals. Ros commenced her nursing career in 1981. She held posts in clinical practice and in nursing education before becoming Professional Development Manager and then Assistant Director in an acute care setting. She then went to the National Health Service Direct as lead nurse, helping to establish the service nationally. She then went on to become Professional Officer in the Office of the Chief Nursing Officer in England, where she led on a range of issues including acute care, research, and modernizing nursing careers. Immediately prior to taking up the post of Chief Nursing Officer, Ros was Director of Nursing, a National Health Service Connecting for Health. This strategic role saw her working closely with the Department of Health, health authorities, and professional organization in England to provide executive-level leadership on nursing, midwifery, and allied health professionals issues inside and outside the organization. Just a few moments to tell you that this is Ros's first time in Canada and in New Brunswick, obviously. And I didn't share this with Ros already, but I'm going to tell you that New Brunswickers are very warm people. And when we connect with someone, we stay connected for a long time. So don't be surprised in the future if someone knocks at your door and asks to eat one of your famous scone cookies that you guys are so famous for. So Ros, the mic is yours.
Good morning. Good morning. Can everybody hear me? Can everybody see me? No. I prefer to walk around. Is that okay? Or would you like me to stand on the podium? You're okay. Can you understand me? When I was at school, I did schoolgirl French. So I wanted to just say good morning in French. I hope this is okay. It's a long time since I did a verbal French anything. 16 the last time. So bonjour. Je suis très heureux d'être ici avec la famille d'infirmières au Nouveau-Brunswick. I wanted to just set the context a little for you in terms of where Scotland is as part of the UK. That's the UK, and Scotland is the top half, starting just above Newcastle. There are 4 countries that make up the United Kingdom: England, Scotland, Northern Ireland and Wales. Scotland is the most devolved of those countries. We have our own parliament, and health is devolved to us in terms of decision making. The things that are reserved to England are things like defence and taxation and social security. Decisions about social security, etc., remain in England. But a number of things, education, health and transport, those sorts of things are devolved and entirely independent. And you may have heard that Scotland is pursuing independence as we go forwards. Wales and Northern Ireland have their own assemblies but don't have the same powers as Scotland. So that's Scotland, and looking at the map, I think there are similarities perhaps to New Brunswick in that we're surrounded by lots of water, but as you can see there are areas of high population, but then we have the islands, the small islands on the outside that have very small populations but still require the same level of health care as anyone else. So a lot of people I know have been to Edinburgh, so I think I circled Edinburgh for you, and some of you have been on the other side up to the Highlands, but it is a beautiful country like New Brunswick, and very green but very wet. And the weather can actually change in an hour. So if you don't like the weather in Scotland, just wait 10 minutes, it will change, is what we say. Scotland is also renowned for its health service, which I believe to be one of the best in the world. But we're also renowned for our poor health. And despite the government investing masses in public health over the years, we were one of the first countries to have the smoking ban. We have invested millions and millions of pounds in public health, but nonetheless we are still, compared to other parts of Europe, suffer higher levels of lifestyle related disease. And so that's our focus at the moment. So all those areas also, I suppose a bit like New Brunswick, all those areas have their own identity. So I'm assuming St John's will have a different identity to some of the other parts, and all those areas of Scotland have a very, very strong cultural identity and a slightly different accent. I don't come from Scotland, so if you're trying to place my accent, don't. This is the Yorkshire, which is down in England, but north, very much north of England, and I hope you're managing to understand it. They don't in Scotland, which is helpful sometimes. I wanted to talk to you a little bit about what I call brand Scotland. So what is the culture and philosophy of healthcare in Scotland? We are very independent. The nature of the geography means that we have to be innovative. So we're well ahead of the game, certainly in the UK and Europe, around telehealth and those sorts of areas. If you live out in those islands up at the top, which is Shetland, and they are nearer to Scandinavia than they are to Scotland. It takes 4 hours to get up there from Edinburgh. You can imagine living in those communities, then telehealth is not something that you choose to have, it's something that you've got to have. So we tend to be a little bit at the head of the game. We have a Scottish nationalist government, which means that it is very much focused and has a strong belief in public service, tax-funded public service. And that's where the divisions between the 4 parts of the UK are beginning to be felt. So in Scotland, our commitment is to a publicly funded, free at the point of delivery NHS, and it is managed by the Minister through myself and the team of directors that I work with. So as well as being all the other things that Virgil told you I am also the Chief Nursing Officer for the whole of the NHS in Scotland. So I have a very hands-on role as well as the very political role. And that is something that we intend to keep. In England, the government in England, which is a coalition at the moment between the Conservatives and the Liberal Democrats, they are looking much more at a mixed economy of healthcare delivery, driven by competition and cost. And so we're finding private providers coming in from the States to take over some of the GP surgeries and other areas like that. None of that is likely to happen in Scotland unless there is a revolution. So the 4 countries of the UK are beginning to diversify. As a very small country compared to yourselves, to have such diversity when people move around the 4 countries quite a lot is difficult. In terms of nursing, in Scotland there are 160,000 nurses in Scotland alone, so it is the biggest professional group in the NHS, and I would imagine here as well. We are regulated by the Nursing and Midwifery Council. Nursing and midwifery, separate professions but regulated by the same body. Our regulator, unlike yourself, is focused very much on maintaining the register and setting standards. We don't have a professional organisation. We have the Royal College of Nursing and the Royal Colleges of Midwives, but they are also unions. So there is, to some extent, a tension that can occur between those 2 roles. So that is different, and so I am very interested in the model that you have here in New Brunswick, which I believe is unique to New Brunswick, but one that I think we would do well to look at. So that's a little background, and I hope that's helpful in taking you forward. So, why did I start as CNO in Scotland asking questions about professionalism? People had not been talking about professionalism for a long time, mainly because people don't really know what it means. There isn't a single definition of professionalism. These are just some slides of nurses in Scotland. These are some pictures of nurses in Scotland, and it shows the diversity of the role and how much nursing's changed, certainly since my career started in 1978 as a student nurse. So nursing roles today are expanded. Nursing roles today are characterised by advanced practice, independent roles, working in many different settings, way out of the traditional comfort zone of the acute hospital setting. I believe that we are better paid than ever we were before. That may be controversial. I know that people have different views, but I can only compare salaries for a starting staff nurse in Scotland compared to, for example, a non-registered professional, and say, and certainly looking back to my own start when I was lucky to bring £100 home a month or something like that, then we are better paid. We're certainly better educated than ever we were before, and I'm very pleased and proud of that, and have been an advocate of degree level education for nurses based in higher education, but with a strong practice-based learning philosophy for many, many years, since I worked in a university. We've also got research. We never had the sort of evidence and things. So I think, in general, nursing is in a much better state and position than ever it's been before. So, my question was, this is just taken from a survey by the Royal College of Nursing. They do this every year, but it's only one bit of evidence which suggests that despite all those things, despite the improvements in research, in education, in pay, in conditions, that morale is low and continues to drop, and certainly the statistics across the UK suggest that that's the case. My own very visible leadership in Scotland means that I spend a great deal of time out in service in all sorts of different settings with the people that I serve, the nurses and the patients. Yet they do talk to me about low morale, despite all the good things that we're doing in Scotland. They talk about feeling overworked, undervalued, morale. I wouldn't want my daughter to go into nursing. I think that's one of the saddest reflections on our profession, when a member of it says, I wouldn't want my own daughter to go into the profession. My own daughter took a career diversion from teaching 2 years ago into nursing, and I must say I was absolutely proud. So we have a saying, proud as punch. It probably means nothing to you, but I was so proud that one of my children decided to enter this fabulous profession. And the opportunities, the career opportunities, how many people could do what I've done and stand here today and be privileged to stand here based on a 3-year programme and some fantastic practical skills. That's all I had. We also know that referrals are increasing to our Nursing and Midwifery Council and have continued to rise. The trend is upwards. There are, of course, a greater awareness of the need to refer poor practice. That's a fact of life, so I take that into account. I also take into account that there is inappropriate referrals made. So sometimes people in service misunderstand where performance management and the employee responsibility stops and starts and a professional one. I take all those things into account, as did the CNOs. But when we looked at the statistics, it was clear that despite those variables, there was an increase in the number of referrals made around nurses in the last 10 years. The reason for those referrals, sadly for me, are around misconduct and competence. And that was the thing. If they had been the real wildcards, you know, the rogue practitioners, we've had a few in the UK, rogue practitioners that you may have heard about, Beverly Allett being one of them, and a nurse in Leeds who, I don't know what drives people, but he decided to actually kill patients by insulin injections. Those are rogue practitioners. Those are the sorts of things that I don't think you can ever. I think those people exist. If it had been those people that was increasing, then I might have sort of gone, oh well, you know, let's not think too much about this. But it isn't. It's misconduct and competence that are increasing. And at the heart of the misconduct is often very simple issues such as courtesy. I think you was talking about civility earlier on. Courtesy, kindness, compassion, communication. Just those simple things. And downright rudeness. We've also had a drip of negative reports, and I don't know whether you have had that similar profile. And these are just some, and I've done this to show that these are different areas. So the first set talk about death by indifference, and this relates to people with learning disabilities in acute hospitals. Now in the UK we have a separate branch of nursing for adult nursing, which is community and acute settings. So that's your adult nurse, I'm one of those. A paediatric field, so we specialise during the first 3 years. Paediatric nurse, you can do postgraduate, I'm a postgraduate paediatric nurse, but you can also, as my daughter is, be a mental health nurse and deal solely with people with mental health concerns across the sectors, or you can actually be a learning disabilities nurse and focus only on learning disability, and that's your career then, unless you decide to retrain for the rest of your life. So, because people are living much longer than ever before with learning disabilities, which is absolutely fabulous, we're seeing more and more people with learning disabilities in the acute sector. And this report, Death by Indifference, talked about a number of deaths that had simply taken place in the acute sector, not by learning disability nurses, specialist learning disability nurses, but acute general nurses who, for whatever reason, had not provided the care that this person required. One of the guys in this report, the guy in the middle picture, actually starved to death. Learning disabilities. The middle one, and there's a follow-up report which is called 74 Deaths and Counting, which was attributed 74 deaths of people with learning disabilities to poor care in acute sectors. So that was again in 2012, a follow-up report to death by indifference. The middle report is just indicative of the number of reports that we get constantly about the care of older people. Now, older people, I'm older. What is older? You know, and so we have this constantly. At what point do you become older? And you know, you have this sort of these people who are 84 and stuff taking the old folks out for dinner and stuff like that, don't you? So it really is, I think, a concept that is difficult for us all to grasp. So I think about the older person as being those who are physically, functionally, emotionally or intellectually impaired and therefore dependent. So that doesn't include me at the moment, though intellectual impairments and some physical impairments, as we were talking about last night, Darlene, then we were talking about our eyesight and all sorts of other bits of our bodies that were failing. But nonetheless, I'm still able to advocate for myself. The number of reports about the care of older people is, I don't know, it's daily. It's absolutely daily. And it comes down to things like care, communication, blah, 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 but also fundamental care, eating, drinking, failure to give sufficient fluids, ambulatory care, prevention of falls, those sorts of things. Yet, interestingly, our statistics, our quality indicators around those things show a general upward trend. So by all objective measures, care in Scotland is better than it's ever been before. By all subjective measures, care isn't as good as our objective measures suggest it is. And so I am really keen to, and one of the things I'm doing in Scotland is making sure that our objective nursing indicators are balanced off against subjective indicators. Because what we know is that if there's something wrong with the system, the first people to tell you there's something wrong with the system is the patients, then the staff, and then it appears in the figures. The third report, which is a report on Mid Staffordshire Hospital in the middle of England. It wasn't Scotland, and it certainly wasn't Wales and Northern Ireland. But nonetheless, it has been a watershed report for nursing in the UK. And it started off investigating hospitalised standard mortality rates, which were higher than anywhere else across the UK. So why was this one hospital having this particular problem? What they told us were, well, I'm sure you can guess, it was the statistics, it's the measures, it's, you know, there's something wrong with how you're counting. So we had a year or so of that. Then there was there have been 3 public inquiries because the patients themselves talked not only about the deaths, but they were deaths that were often due to lack of care and attention, poor communication, the usual things. We had our final report into Mid Staffordshire a couple of months ago, and that's called the Francis Report, and I would advise any of you to look on the website and just pick out and read the Francis Report. The last report looked at governance and professionalism. It talked about the division between the regulator and the professional organisation and the unionised nature of the professionalised organisation, as well as a failure in leadership, a gap between those at the top looking at corporate indicators and CQIs, and those at the point of care who were reporting a very different experience. The nurse leaders, who were they listening to in mid-staffs? I'm afraid they were listening to the corporate responsibility, the corporate tale. So these are just 3 examples. We've had a constant drip drip and continue to have a constant drip drip. Certainly in our English hospitals, I'm not complacent about Scotland, but we've yet to have anything as fundamentally disruptive as the mid-staffs reports. But I feel a sense of responsibility regardless, because this is the nursing family. I would feel all of us to have some responsibility for the failures in care. And those failures in care have placed the political spotlight in England on nursing and led to a degree of political interference in the profession. So the government in England are looking at, for example, and saying things about how nurses should be educated. We have a phrase that's very popular amongst our media, which is too posh to wash. Do you have that here? Too posh to wash? The idea that students today, because of their education, are somehow unwilling or unable to deal with the day-to-day fundamentals of care, and that they have no sense of vocation. I absolutely challenge the veracity of that statement. I am yet to meet a student nurse in my career as the CNO who has not got the same drive and values that set me on my path, and that their education is preparing them to be caring and compassionate, indeed perhaps more caring and compassionate than we were taught to be. But there is something around the context and culture in which they then are asked to operate which either diminishes that, or they feel a sense of dissonance between what they want to see and what other people expect to see. So the government down in England are getting quite hands-on about how nurses should be educated. Many of them have got mothers who used to be a nurse 30 or 50 years ago and therefore would like to go back to the apprenticeship system. They're talking about, they're really challenging our regulator, the self-regulation model, and really challenging whether or not the profession can regulate itself in the way that it is. Luckily, I'm in charge of regulation in Scotland and it's devolved, so I don't have to worry about such things, and I have no intentions of doing that. But nonetheless, when those things spread politically, it starts to spread. So we are in a difficult position, a difficult place. And the UK CNOs wanted to know what might have happened to create this, and why some people choose to do the wrong thing. Nobody here believes it's not the right thing to be courteous to a fellow nurse, doctor or patient. Every nurse knows it's the right thing to do to wash their hands. Yet, I saw some statistics on your television this morning. I've forgotten the region, so I'm really sorry. I think it might be Halifax. 52% hand hygiene compliance. 52%. It's 98% in Scotland. We've got 98 nurses. I've got 98 compliance. Sorry, thank you. I forget how well we're doing in those things. I mean, our HAI is, it's fabulous. It's still a problem, but we've reduced it. We've got no ventilator infections in hospitals. Our safety record in Scotland is phenomenal. Now, I worry about that 2% of nurses who still choose not to do the right thing. Why are they choosing not to do the right thing? I don't believe it is that they don't know. I believe there may be some areas that they don't know and they may need some education, but I think it's much more complex than that. And this is my this is my hypothesis. It's got no evidence base, it's a purely hypothesis, and it's what started me off on our journey around professionalism. This is taking you through changing models of healthcare and the paradigms of how healthcare quality has been driven. So I've tried to put some sort of pictures up to indicate the era as it was, so I didn't have to put figures, but we start off with what I call the trust paradigm. This is based on, the model that I use is based on the work of Julian Legrand. And Julian Legrand offers 4 ways in which you can drive quality improvement in an organisation. I've adapted that framework to professionalism because I believe that there may be the nugget in there. When I practiced all the time as a practitioner, the trust paradigm was very high, i.e. there was no external measure of quality. It was down and expected for the nurse on the front line. We did have sisters in those days. In Scotland we've got no sisters or charge nurses, we call all senior charge nurse. But down in England they still use those old-fashioned terms. But in my day it was a ward sister, and I always felt sorry for the men who, you know, like why? Anyway, the trust paradigm was absolutely as it was, which meant that it was very much down to the ward sister, stroke charge nurse, and the nurse and staff on the ground and the doctors, etc., to determine the quality of care, and nobody questioned it. We didn't measure. We didn't know. And I mean, we assumed we washed our hands in those days, but I'll tell you what, I've no idea, because we didn't measure it. The other thing that the trust paradigm did work to some extent, but I don't know about you, but I was taught, for example, that a healthcare acquired infection was almost like an inevitable response to illness. Not something that I had any responsibility for, it just happened. But that was how I was taught. It was just accepted. Oh, they've got an infection. Nobody said, where does the infection come from? Oh, you would have just said, it just happens. DVT, oh, so you get that with surgery. It's one of those things, we'll try and prevent it a little bit, but it's not me. Falls, oh dear, they've fallen. You know, it was that sort of thing. We didn't measure anything. So in the sort of mid, which is my sort of era, is the mid-era, there was a shift. They introduced into England a much more managerial model, but the trust paradigm remained very high, i.e. the standards of care remained the responsibility of the professionals, but there was a managerial oversight in terms of more standards to standardise that care. Still no measures, of course, no measures at all, but there were standards in place to try and reduce the variability in how we work. So we began to shift away from that trust model of it being down to us to determine the quality of care. Standards put in place, and we were trusted to deliver those standards. Well, come the I suppose the 1990s, and since then, the quality of care continued to remain an issue. So despite trying to reduce variability through standards, competences, etc., we got to the 1990s with very problematic HAI in particular, I think, which is symptomatic almost. If you've got that wrong, everything else is pretty much poor. And so what can you do? Well, Legrand tells you there are 2 things more you can do besides trust. If trust is not working, then you set targets, which is what we've done, and you increase the voice of the consumer. So we've seen for the last 10, 15 years in the UK a very heavy focus on targets, and in order to meet targets, a great deal of not just standards but protocol driven care, a great deal of pressure from the media and from patients and the public driving forward the quality of care. So patients no longer accept that it's okay to get a HAI, whether you're in community or not. It's not okay to have a poor GP consultation. It's not. So it isn't that I'm against the appropriate use of targets and voice. I think they do, particularly voice, serve a great purpose in driving up quality. My concern is the impact that has had on the profession. And I believe that the shifting paradigm equates to a drop in professionalism, i.e. the will to do the right thing because it's the right thing to do. And this is what I think, how it manifests. This is how I see it. The targets and voice culture means that you've got clearly differentiated and segmented organisational positions, roles and responsibilities. So you will find the acute sector trying to, A&E trying to meet their target, the emergency room trying to meet their target, 4-hour waits as it is in Scotland, whilst the medical admissions unit is trying to meet a different target. The surgical unit's trying to get the waiting times down because that's the biggest thing. The GPs, they're focused very much on driving public health and reducing smoking and things like that. So there's a very clear differentiation and segmentation of people's roles and responsibilities as they try to meet these targets. We are constantly exhorted in that paradigm to work as multidisciplinary teams. In fact, we're discouraged as nurses to state our position and contribution other than within a multidisciplinary team. But whilst we work in multidisciplinary teams, we don't share responsibility. So when Frances came out and there were discussions, Lord Francis's report talked about failures in nutrition, it wasn't a problem of the multidisciplinary team. It was a failure of nursing. So there is, although we work in multidisciplinary teams, we don't share responsibility for the whole. And I believe that's part of the culture. I do believe the target culture has driven, to some extent, that differentiation and multidisciplinary teams not working together because each has got their own driver. This is one that I particularly dislike. I call it widget thinking. Nurses seen as inputs or company resources that can be trained, manipulated or used as required. Does that make sense? So rather than a profession determining its role, responsibility and contribution, we are constantly described, and I don't know if it's the same for you, in terms of our number. How many? What type? Where are they working? And if there's a gap in the service, the nurses expand to fill it, not literally, you understand, but metaphorically. We expand, we take on more constantly, and we expand to meet the gap. So if you want the 4-hour target met, let's have this nurse doing discharge, let's have this nurse doing this, let's have this nurse doing that. Company resources to be manipulated or used. The other professions do not suffer that. They don't allow that. We have got to stop asking permission and telling people to listen to us. They cannot deliver anything without you. They cannot. Use that. You are the biggest, most powerful profession. Assume the role and go for it and stop apologising and asking. One of my colleagues talks about meetings with... Thank you. One of my colleagues describes a room full of nurses and doctors, and I hope you don't feel offended by this. This is this person's experience and my own. I don't put it onto you. We describe the nurses in the rooms as puppies because they are eager to please, head cocked to one side, listening. Yes, oh, yes, yes. What can we do? What can we do? Like this. Whereas the doctors in the room are like cats. They sit back, they wait, and then they spring. They've been very good. We've a lot to learn, fellow nurses, from our medical colleagues around political influence, positioning, and an assumption that the system cannot and won't work without you. We have increasingly a mechanical view of care as competence sets or tasks. Now, when I was practicing many years ago, it was a task-orientated model. We called it task-based nursing and spent the 70s telling each other how bad that was. Yet my experience is that it is just as task-orientated as ever it was. In fact, increasingly, I believe it's becoming more task-focused. And that care is fragmented, the process of care is fragmented in a way that it hasn't been. And so basically if you've got the set of competencies, anybody can do it. Why do you need a nurse if you've got a set of competencies? Why do you need a profession if you've got a set of competencies that can be trained? Well, I believe that nursing is more than a set of competencies. Competences help us understand and define the knowledge, skills and attitudes required for safe and effective performance in a given situation, taking into account ethical and contextual issues. But it is much more than that. It is the will, the belief, the vocation, the wanting to do that in the way that we do. And that's the bit I believe I'm worried and concerned that we have lost or are losing. We've seen a downshifting of work from medicine to nursing. So I was recently on a ward in one of the hospitals, and I saw the poor nurse with her red tabard on for 6 hours. That was the medicine round. Because, of course, we do IVs now. Polyfiller nurses spreading out. Yes, we'll do the IVs. 6 hours. By the time that poor woman had finished doing all the medicines, all the good checks and all the things, then done all the IVs and made sure that all that was in place, 6 hours. Not saying it's wrong that we don't do medicines, because actually we did it for the right reasons, to provide continuity of care. But it's become a task, not a part of me delivering a package of care to you. It's become a task. And of course we are then, downloading our fundamental care onto assistive staff. And assistive staff that we are not prepared to give the full education, training and development that we had, but yet we critique them for doing it. I think the assistive staff are in a very difficult position. And my job covers the assistive staff, and we have a programme in Scotland. They have their own codes of conduct, a formal induction, education programme, etc. And I hope it's better. But I still think that they are in a very difficult position. There is constant tension between the clinical caring and organisational priorities as a consequence of the target culture. There is a perceived loss of professional autonomy, which leads to skewed decision making. So you don't really want your individual to go into hospital, but the targets, the things that are driving you means that you've got to send them in, because what else can you do? And then when they get in, there's another set of another set of targets that say they've got to be out of there by 4 o'clock at a certain time, so then you're pushing them into a bed. So everybody's got skewed decision making. Micromanagement, top-down procedures and behaviours with top-down bureaucratic monitoring processes and upward reporting. The nurses constantly in Scotland talk to me about the data burden. Now, that data burden is very much driven by a target-driven culture, a protocol-driven culture. The fact that we do hand hygiene measurements, and I am very pro all those things, but you have to keep it all in context. My fear is that that micromanagement leads to people doing things because there's an audit as opposed to because they think it's the right thing to do. So how many of the 98% of nurses who wash their hands properly, because we look at opportunity and process, are doing it because they want to and because they know it's right, or because they fear somebody's watching them, particularly the patients these days, which is great. I'd love to think that that wasn't what drove it, but I really worry that our HAI statistics and other good things that we're doing is driven at the front line, not by the leadership, not by people like yourselves who are innovators and driving improvement, but the actual people who do the work on the front line, who are actually counting the number of falls, who are picking up the carpets and those sorts of things, are doing it because they think they'll get in trouble if they don't, as opposed to they want to do it because professionally that's what we do. You may agree with any of this. There's a lot of rhetoric about values, but still, essentially, in a target and voice-led paradigm, you have a carrot and stick approach to staff. And finally, there has been, and I regret this personally, a lot, almost an anti-professionalism. So it may be different for you, but there are no rites of passage for nurses now. So you will recall, I don't know, looking around, there's so many young people here, but those of you who are as old as me may remember the rites of passage. I don't know what yours were, but for me, it was getting my badge, actually getting a badge from my regulator, getting my hospital badge, getting my belt, and my buckle. The buckle, can you remember the buckle? Donning a uniform and being celebrated as a new professional, entrant to the professional. None of those things happen anymore. Now, I'm a bit anti-uniform, I have to say. I'm a bit of a naughty person in that way. I think uniforms that are used to exercise power and things like that is totally wrong. I don't believe in that. But I look at, for example, our colleagues in the police, or in the army, for example, where when they are in a ceremonial situation, they have a ceremonial element to their dress. And I recently took my directors of nursing out with the army reservists in Scotland, and we did all sorts of tests, jumping in water and swimming and all sorts of things. But on the night we actually experienced what it's like in the ceremony of a military, where you don't wear certain things. You have to wear dress that covers. You have to wear your badges. You have to follow things in a certain way. And actually the pride and passion that generates is underestimated. And I regret now, after years of being very radical, and well, it's not radical, it's just ill-informed really, about hating uniforms and all that went with that, and everybody should be an individual, you know, grow your hair, pierce your nose. I've got a couple of piercings, I won't share them with you, you'll be glad to know. But you know, I was always of that. If you're individualised about patients, then you must be individualised and recognise diversity in your staff. However, there are times and places, is what I've come to think about it. And actually, the students in Scotland regret the loss of ceremony. So I went to a graduation a few weeks ago, and the graduation saw the nurses coming across the stage. They had their hats and caps and things, and they tottered across the stage. And I do say totter because a lot of them had high heels, short skirts and big boobs. So I don't know how that translates in French. What was the French word for that? How did it translate in French? Boobs? No? I can't remember that from my schoolgirl French. We didn't cover that in French. But they did. They tottered, many of them, across the stage. The men, interestingly, because the national costume in Scotland is people are very proud of the national costume, so the kilts. The men actually looked fabulous because they were in their kilts. And there was an element of ceremony. They dressed up for that ceremony. The girls looked horrendous. After the nurses came the paramedics. The paramedics all had their greens on. Every single one of them had their greens on. They walked across the stage with their uniforms, accepted there, and went down. And afterwards I said, why did you wear your greens? It was great to see, but why did you wear it? And they said, well, this is what I've done it for. I didn't get a qualification today. I entered the profession. And this is my uniform. This is what demonstrates it to me. So I think there's something that we might ask our students about the ceremonial element of it. Do we celebrate the rite of passion and create the pride and sense of ownership to your profession that I think characterised us very much in the 70s and 80s in the trust model, where the responsibility of becoming a professional was the thing that was drummed into you right from the beginning. You take on the mantle of a registered nurse, and that is of itself a source of pride, but of responsibility and accountability. The loss of some of those things, I think, it means that there isn't the same sense of identity, perhaps amongst our students. The impact on nurses, this is what I've seen. Dissonance, a sense of dissonance. This is not what I came into nursing to do. This is not what it's about. I don't want to be trying to fit my practice into this false model that doesn't value the things that I value, which makes the choice to do the wrong thing even more intriguing for me. Alienation, a great sense of alienation. I got a company to do a small study of nursing morale in England, not in Scotland. That's naughty, isn't it? Anyway, so they did it on a few wards in England. I asked the director of nursing if I could do that. But what they found was that the majority of nurses on these units were clinically angry. Clinically angry. So they filled in a scale of anger that you use with anger management in mental health care, and they were clinically angry. They weren't. They were just angry and alienated from what they were doing. Their job was they loved being a nurse but hated the job. Do you know what I mean? They valued their career but hated what they were doing. Now that's not everybody all the time, but particularly in some areas I think that's absolutely the case. Medical assessment, I don't know whether you have them, but those assessment units where people are going through and going through and going through, I think particularly general elective surgery, I think is another area. Less so out in the community, but I have to say increasingly I've been hearing the same alienation in our community nurses as in our acute nurses. And less so in mental health and learning disabilities, where the professionalism model has remained very strong. A loss of identity, and somebody said this to me last night, who am I? I think it might have been Kathy. Who am I? Where do I fit? How do we fit with social care? Where do we all fit into this world, this new and changing world? A sense of disempowerment. It's not in my control. The control for the quality of care lies with someone else, not me. Anger and frustration, I've talked about. Lack of discretionary effort, i.e. doing more than the job. I'm not paid to do that. We're just having a discussion around mentorship. I'm not paid to do that. Will you do more polyfiller? I'm not paid to do that. Is becoming the sort of terminology. Now that's I can understand that, that's right, because you shouldn't just keep expanding to fill. But there is something about that, when that discretionary effort becomes, leave that patient in that bed because I'm going off now. And that's what patients report to us. So the night staff are coming in, the day staff are coming on, so and so, the district nurse will be in next, so we'll leave it for that person. Low trust with colleagues, defensive use of codes and accountability to watch your back. So record keeping not because it's the right thing to do, but so that you protect yourself. And I know we're talking about legal requirements, I'm totally up for it, but when codes of conduct are used to defend, or the good quality things that you're doing is about defensive accountability so that the patient can't somehow stab you in the back or something like that, I think that is very, very disturbing. Enforce compliance. Are you doing things because somebody's watching you? And gaming or subversion, and that's what I absolutely think may be happening in the choices people make. I.e., in order to if you feel uncomfortable with the system, you subvert it in some way. I'm trying to think of an example of, I don't know. If you go into a hotel and or McDonald's or something like that, and they expect you to work in a certain way, and the staff they've got to say good morning and all that sort of thing. I'm of the belief that putting a sign up saying smile and say good morning doesn't work. Good morning. It's like that. And so they game and subvert. And that's human nature, we all do it. You will do it somehow in your role. So, is the answer lies back? Does it lie back with Lucille's day and my day? Does it lie back in the good old days when nurses were nurses and, and doctors were doctors and patients knew their place? Does it lie back in the past? Do we go back to the trust model? No, is my answer to that, because the trust model did not work. HAI, all the things that I've taught you about, we didn't know what patient satisfaction was like in those days. I have no idea, but I dread to think. There were some things that we did well, and those are the things that I tried to alert you to today. So no, not for me, back to the future. We need a refreshed and revitalised view of professionalism, because I believe it could be the missing link, the thing that provides your internal compass, morally in terms of the choices that you make on the day and at the point of care, but also professionally provides us with a map of where we want to go and what we want to be like, not what people think we ought to be doing or ought to be like. So for me, we need a refreshed and revitalised view of professionalism. Why? That's the gap, that's Scotland's gap between supply and demand. That means that we have not got enough money to meet the healthcare demand in society. That's the same globally. I was at the EU chief nurses only a month and a half ago in Ireland, and there was everybody from across Europe. It was awful because the Greeks and the Spanish are in such a terrible state. Actually, we're not actually in such a bad state in the UK. But nonetheless, we cannot keep doing what we've always done, as the Minister said last night, with the resources that we've got and the increased demand. It isn't the money, it's the demand that's changing. Health inflation, people living longer happily, but people living with lifestyle diseases. So the inflation and the cost of the healthcare system, the lifestyle diseases, and you will know that 70% of the diseases that most people suffer are preventable diseases. Even the cancers we know are preventable. And I was looking at some stats in the newspaper yesterday morning showing that coronary heart disease in New Brunswick remains extremely high. And therefore, that's lifestyle. That is a lifestyle choice. And so we can't keep living like that. That's demand. Technology is a game changer. It's not. It's changed the world. Can you imagine a world without technology, without pin and chip and social media and internet and www this. Well, do you know what? It's no use railing against it. It's like gravity. It is here. So we can't go back to a time when people didn't have computers, because now you do everything. You make relationships on the computer. You complain on the computer. You create community on the computer. You get information from the community. We will no longer be taught how to do a procedure. That, I believe, that is so old-fashioned. The model, we do this, you put this, and then you do that, and then you do this, and then you do that. How's that going to work? How's that going to work? When patients know more than you do about their condition, when evidence-based research lasts about 8 years or something like that, the evidence base is changing, and patients demand individualised care, personalised care about me, not about homogenous packages that you're going to tell me I need. The internet and technology has completely changed the game, and we professionally, I'm sure you don't, but the number of nurses that I hear that sort of go, oh, you know, if only we didn't have the internet, if only we didn't have this, and well, it's here. Use it. Be there. Be at the front. Be the pioneers. Be the pioneers. And the increasing voice of patients and the public in their healthcare is required. And more, I mean, again, there are communities of patients doing research on the internet and using social network to create care packages and things like that. In Scotland, we've given some of our public healthcare who require healthcare, such as older people and people with learning disabilities, they have the money to spend how they want. If they want to buy a caravan with the money, do you know what a caravan is? Sorry. Yeah. If they want to buy a caravan because that will get them out and about more and increase their health, they can do that. They don't need necessarily us to tell them how to spend it. So it's very, very different. The other reason, I think, is because, you know, let's get away from the old stereotypes. These are English stereotypes, you know, sort of good nurses and bad nurses. And this is from a piece of research by Nicola White, who was a writer in residence last year in the University of Edinburgh, talking about nurses, featuring a cast of drunkards, saints, harridans, angels, sexpots, wimps and mavericks. And actually, when you look at the media stereotypes of nursing, then we fulfil all those. Well, let's create our own stereotype and let's get rid of the old ones. And I do believe we need a new brand because of that drip, 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 drip of poor reports. And we can no longer take for granted the goodwill, respect and advocacy of the people that we serve, because some of them experience poor care. The majority, I think, experience great care, but for those that don't, that is their memory. That is the thing that stays with them for life. It is created, and every nurse that does the wrong thing that day is not only creating an image of that nurse, they are creating the image and the perception of the profession and the hospital and the primary care unit or the board that they work in, and indeed for us in Scotland, the reputation of the NHS. Nurses are very often the benchmark against which the rest of the service is held. If they have a bad experience of nursing, everything's poor. And they don't say there are 100 other good nurses and I just met a bad one. They say, nursing today. Now that's human nature. We're not going to change that. We're not going to change that. So we have to, I think, refresh and revitalise our view of professionalism. So with all that behind me, I set up a programme board on behalf of the UK CNOs, but mainly on behalf of the nurses in Scotland who felt that we wanted to do something. It was a programme board that was cross-UK. It had regulators, the Professional Association, but academic researchers, practitioners, HR professionals. We had a full gamut, all talking for the first time about this vital ingredient, this lost, if lost is the right word, thing. We looked at the evidence, and you've got the report on your. I want one of those things. I want one of those. Can I have one? I'm always losing my data stick, so one tied around my wrist might just work for me. We looked at professionalism within modern healthcare settings. What does it look like? How do you project it? We talked about the emotional cost of professionalism. So we tried to articulate what it looked like and what the modern healthcare setting would require of it. We talked about how we could facilitate professionalism. We've got professional standards and regulation, that's just one part of it. But we talked about cultural issues. We talked about how can directors of nursing and other professionals create a culture that allows professionalism to thrive and values it. We talked about recruitment and selection, leadership and role modelling, education, training and development, promoting and communicating professionalism. We also bravely, I think, talked about measuring professionalism for the first time. If you don't name something, you can't do anything about it. And although I've not meant to be negative about measurement today or about targets, I think they all have their place. But there are certain things that if you don't name it, make it explicit and get some feedback on it, then it remains a subjective concept in your heart that is accepted in a different way. So maybe those nurses who are not meeting professional standards have a view of professionalism that may be different from yours in the room. And I wonder if that's the case, that getting through the day and doing the job, doing just enough to get paid, meeting the target, those sorts of things have become what professionalism is to some people, when for us it's entirely something different. So we needed to measure it, and looking at tools and how we use those tools, and we made some recommendations. We concluded that professionalism really matters to the people. That nurses recognised my slides 10 and 11, the ones that talked about how it impacts on behaviours, but also how they felt disempowered, alienated, those things. They recognised that picture. It wasn't just me. Because professionalism is frequently described in terms of its absence and negative values and behaviours, it was very difficult to articulate it. So we decided we needed to shift to articulating, then reinforcing positive behaviours rather than just expecting it to be in the heart of people simply because they've been through a programme. And we also thought about how we would measure and support that in order that they enact the quality agenda. We want to look at how we can mark the transition to being a registered nurse, but I want to do that with the profession as opposed to my maybe old-fashioned ideas. But certainly the students were very clear that they felt they no longer made a transition to the profession in that very distinct way that in the past, and that they wanted that. And we also concluded that there are predictors of professionalism or the lack of it. Therefore we can select, nurture, and then continue to nurture it in the light, or make sure that that light stays alive in people. One of the things that we discuss in the paper is the conscientiousness indicator. Donald Murphy, who's done that piece of work, suggests that you can, well, it's not suggest, research shows that you can pick up a lack of conscientiousness in students very early on, the ones that don't fill in their child protection, don't get their assignments on time, things like that, you know, almost like a lack of conscientiousness. And then that pattern continues apparently through to registered practice, a lack of conscientiousness. So if we can understand why that person is not as conscientious in their early career, then maybe we can nurture it, keep it alive. However, I'm very clear that the problem, if the problem is the right word, does not lie with our new graduates. I don't believe that to be the case. I think we should do everything we can to give them the pride and the passion and to nurture it and keep it alive. But I don't think that's where the problem lies. I think the problem lies somewhere within the milieu of day-to-day practice and variable beliefs around professionalism. So this is what we decided to do, and I thought I'd use this little bit. Where's my 5 minutes speaking? Am I all right? 10 minutes? Oh, I'm so on time. So on time. We decided that these were the recommendations. Now, these recommendations were for the whole of the UK, and they've been taken forward in different ways by the CNOs. If you think about the situation I alerted you to in England, where that government is very much thinking along the lines of competition to drive standards and improvements, and cost-driven, you know, payment by results, all those sorts of things. That's very different from in Scotland, where our response to the pressures that we're facing economically and in terms of health inflation and increasing demand and lifestyle illnesses is to drive improvement. That is what we've done, and we are all chipped with IHI improvement methodology. And agree with it or not, it gave us all a common language. And so we have a number of collaboratives which we are using across the health service to drive improvement and to reduce waste, variation, harm and variability, and to increase frontline ownership of quality, because of course quality improvement starts with people, not from the top down. So that's our response, and it is different in the other 4 countries. So this spoke very much to the culture in Scotland, I have to say, and we've set up work around all of these things. Develop and test and publish a vision of professionalism. We've recently put out a Workforce 2020 vision that took the views of 10,000 people across Scotland. That's not a lot, out of 160,000 nurses, for example, but nonetheless, it's to get 10,000 people to respond to a government-type initiative is brilliant. And so we've set some values that we've all agreed to, and we are now in the process of mapping those values to professional indicators. We've incorporated professionalism and the requirement for organisations to support professionalism and professional practice into what are called our governance structure. So you will have clinical governance, I would imagine, financial governance, things that the organisation has got to do to meet its legal and statutory requirements. We have staff governance. All NHS boards and organisations in Scotland have a set of standards that they must meet around how they treat their staff, in and around the education that their staff have access to, and they are held account by us to those things. And so we've included professionalism in the staff governance policy. We are looking through our person-centred health and care collaborative. So we've got a SAFE collaborative, an efficiency and productivity collaborative, an early years collaborative, a person-centred health and care collaborative, and we've just got one around acute sector that's spanning the acute admissions and working across the whole system to bring all that together. But as part of the person-centred health and care programme, we're looking at the support mechanisms. How can we embed the time for supervision? And really doing it, not just saying we are going to do it, but business case, staff it up to people having the support to recognise that nursing as all healthcare professions is, but particularly nursing, because of our 24-hour, etc., 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 is incredibly, being a professional is costly to you as an individual. So how do we support people? Defining the culture for professionalism to thrive, and I could share you the model, but I haven't the time. Reliable supervision, as I say, linked to 3. Putting professionalism into the normative processes. By coming up with the indicators of professionalism, we're developing a 360 tool, which will be part of everybody's normal PDR. So, along with your end-of-year review or appraisal, whatever your process is, you will be also assessed in Scotland by a 360 review of your professionalism and the extent to which you've demonstrated those indicators. It's very brave and a little, it sounds a bit against what I've been saying, but I think it's the only way that you can embed things in, and then once it's embedded, then it can thrive again. Recruitment and selection, we've got values-based recruitment. We're looking at recruitment across the universities, moving away from just taking people by paper. They've got to be seen. They've got they will have the professionalism indicators and the extent to which they can demonstrate the capacity. Professionalism for senior leaders, doing some work with our nurse directors to understand the difference between a referral for OD purposes and a referral for professional purposes, but also what are their professional responsibilities, what's their accountability, what's their role. Reinforce personal responsibility for learning, reinforcing personal accountability in codes through a national programme. We shouldn't have to do that, but many people in England and the UK don't understand the difference between the RCN and the Nursing and Midwifery Council, don't understand the difference between the codes of conduct and organisational policies, unfortunately. So we're actually purposefully putting a national programme that takes people through all that again. National input into graduate and postgraduate qualifications. I've got a review of education that will be published in a couple of months, and that will have again the professionalism model and the indicators embedded in the heart of pre and post registration education. I'm going to commission research into, I have commissioned research into what the symbolic and ceremonial aspects of nurturing professionalism and pride might look like and how much that would cost. And we will then measure the impact. So that's where we are. I wanted to end with grandchild. Where are we, all the grandmums to be and already are? Well, this is my granddaughter, Jennifer. So wherever Jennifer is, it's my favourite name. Where's Jennifer? Oh, and she's over there in a denim jacket, I know. Anyway, that's my Jennifer. She's 3 years old, and I have 3 children, but Jennifer is my eldest daughter, who's 32, her little girl. And here she is, being socialised this Christmas in her first Noosa's uniform. Yes. As we opened it, my daughter sort of went, "Oh, Mother." But you can see how happy she is. The reason I put this up is actually more important than just to remind myself of how much I love her and how much people mean to me. But the reason I put it up is because I sincerely believe that what we do today is going to be Jennifer's legacy. So the profession, if she goes into our profession, what we do today will determine her profession. We cannot sit and just let it carry on. Let's do something. I decided to do something. I may not have the right set of solutions. I don't know. But I've opened the debate. I've made it explicit. I've got everybody talking about it. And I'm making some very, very normative interventions to make sure that it's not just talk, it's reality. Thank you.
Very much.
Thank you.